My job this month in selecting highlights from the August articles in eCancer really quite difficult, because not only are there a lot of articles, but they're very, very high quality. And I'm going to just pick out 2 or 3 for your interest and to make you enthusiastic about going and checking the whole detail. I'll just give you the headlines. First of all, a couple of case reports from India. The first one is from Kerala, and that's from Kuriakose and his colleagues. And it's about a lady who was perimenopausal, multiparous, and she had a history of 1 month before admission to hospital of an epileptic seizure. She recovered and no problem, and then was admitted to hospital in Kerala with full-blown seizures and central and nervous system failures. And the biochemistry revealed all, and she had a hyponatremic pattern, and when she came round with appropriate treatment of the ADH-like syndrome, she was able to give a full history, which included problems with vaginal discharge and pain in the pelvis. Colposcopy revealed carcinoma of the cervix, and it had small cell components in it, and it was then clear that the small cell component was responsible for paraneoplastic syndrome. Indeed, this patient was presenting with a carcinoma of the cervix with an inappropriate ADH secretion. She had local treatment, but regrettably did not do well. She developed distant metastasis inside several months, and sadly this is merely a case of increasing your awareness of the possibility that small cell carcinomas, which are capable of secreting lots of different hormones, but in this case ADH, they can even be found in the cervix. So a high level of suspicion is needed. The second Indian case report is of a spindle cell carcinoma. Typical head and neck cancer. India probably the Indian oncologists are probably the experts in the world in the diagnosis and management of carcinomas of the head and neck. And in this case, this was a 60-plus-year-old man, chronic alcoholic, so the usual sorts of environmental embarrassment on the head and the neck, and this man had a very fast-growing carcinoma of the tongue. And he said that it had grown to the size it was, a couple of centimeters, inside 1 month. So that was quite remarkable. The history wasn't. Now, the interesting issue was the pathology, because it turned out to be a spindle cell carcinoma. These are really rare. Only 1% of squamous cell carcinomas are spindle cell varieties, although it might not surprise you to know that Virchow, the father of oncopathology, had described spindle cell carcinomas inside squamous cell carcinomas in 1865. Important to get this histology because it's a poor prognostic factor. These patients usually do worse, they metastasize early, and they're difficult to control locally. This patient has done well so far. Hemiglossectomy has sorted out the local problem, and after over a year's follow-up, there's no local relapse and no metastasis. We are blessed at eCancer with a stream of high-quality reviews, and this month you'll read Adaptive Immunity in Cancer Immunology and Therapeutics by Emma Spurrell and Michelle Lockley from the Whittington Health NHS Trust in London. And this is a nice and short and easily understood overview of adaptive immunity. And it's very, very important that those of us medical oncologists in particular and clinical oncologists who are used to understanding cytotoxics and why they work and how they work and when to use them and what the side effects will be, we get our heads around this new breed of drugs which have been focusing on the checkpoints within cells, which are important for immune regulation and immune control. Ipilimumab, of course, stormed through the barriers and made us sit up and face the challenges of a completely new way of looking at anti-immune mechanisms of treatment, because ipilimumab was not an antibody against the tumor antigen, and so it's not against any specific kind of tumor. It's an anti-cytotoxic T lymphocyte antibody. So it brings with it a different range of side effects, such as reactivating autoimmune conditions, ulcerative colitis-like lesions, thyroiditis-type lesions, etc. If you're wanting to get a quick update on how ipilimumab works and also what's happening since ipilimumab, then I commend this review to you. Because what's happened since ipilimumab is anti-PD-1 antibodies and anti-PD-L1 antibodies. And this is the next exciting opportunity for manipulating the immune system so that patients' own immune system can be gingered up and put into top gear to tackle the patient's own cancer. It's appropriate that following this review article, there's a conference update on melanoma. It's appropriate because ipilimumab was first shown to be active in melanoma, and the anti-PD-1 antibodies are following suit. In fact, really impressive response rates have been seen in melanoma in 20, sometimes 50% of patients with the original drug and the second generation drugs, if you want to call the anti-PD-1 antibodies second generation. The interesting and very, very encouraging thing about patients who get responses from these immune drugs is that they are durable responses, and that's all giving a great deal of optimism in the melanoma community. Alessandro Testori set up a conference late last year in Rome, which was involving all the folk who are involved in melanoma, the patients with melanoma, the patient advocates, the charities who are involved in raising money for research, the researchers themselves, and the various kinds of doctors who look after melanoma. This is a group called the MIB, Melanoma International Board, and it had its first meeting and discussed 3 different areas of strategies for the way forward. Strategies which involved the whole community, led by the patients. I was most impressed to see the patients at the top of the list. And then there was a science strategic view, which of course underlined what the previous review was talking about, the importance of unraveling all these other immune checkpoints so that we can find out that there are more targets than the ipilimumab and the anti-PD-L1 targets, and hopefully another battery of new drugs will come along. And then there were sessions on the clinical side of melanoma management and how multidisciplinary care is so important, the newest things in surgical management and in medicines combined with at the time of and after local treatment. The MIB plan another meeting later this year, 2014, again in Rome. And lastly, the most exciting paper, intellectually at least, in the month's batch of eCancer papers is from Carrie Lenneman from Vanderbilt and some of her colleagues. And they've been trying to explore the mechanism of cardiotoxicity associated with trastuzumab. We're not sure if all the HER2 targeted drugs produce the same sort of cardiotoxicity or not, but what we are sure of is that if you give one of these HER2 new targeted drugs with an anthracycline, you can almost guarantee that 1/3 of patients will get cardiotoxicity. And what the group in Vanderbilt have been looking at is a new pathway. And they've been intrigued by the fact that there is a receptor for neuregulin and Herceptin. So it's called an NRG, that's the neuregulin HER2 ligand. And it's rather important to know that these receptors can be found in the medulla oblongata, and therefore they are important regulators of vasomotor tone. If you take a mouse model and look at the medulla and disrupt the neuregulin HER2 pathway and the signaling pathway, then what happens is that sympathetic nerve output is increased, and therefore, of course, blood pressure is increased. And this group in Vanderbilt hypothesized that the anti-HER2 agents would cause the same thing, increase the sympathetic tone, and change the catecholamines and the neuroregulin. So they've taken 15 patients with breast cancer who've newly treated, not had any other medicines, and certainly no anthracyclines, and no beta blockers or any other drugs which would affect the relevant blood pressure pathways. And they showed that in these 15 patients, after they were given 3 months of anti-HER2 treatment, the neuroepinephrine went up, the NRG went up, the blood pressure, the systolic blood pressure went up, and the left ventricular ejection fraction went down. So just 15 patients, it's early days, but it is really quite interesting to think that we may have a pathway now which will give us better markers, better biomarkers than what we have at the moment, which is troponin, and is not the best marker. And by looking at the physiology of the control of the sympathetic nervous system from the medulla down to the heart, that we might well find an important way of screening patients for likelihood to get cardiotoxicity from HER2, anti-HER2 antibodies, and also perhaps in monitoring the onset of cardiovascular problems in patients who are on long-term drugs. What's of importance and what has to be checked, and is difficult to do in an in vivo situation, is that the NRG HER2 signaling pathway and the receptors are actually also expressed on myocardial tissue, and they regulate in mouse models of myocardial tissue intracellular signaling, which is required for myocyte growth, survival, and repair of damage caused by, for instance, trastuzumab. So really intriguing, and clearly big studies are required, a lot of follow-up, and monitoring of this sympathetic pathway with norepinephrine and NRG levels and systolic blood pressure, of course. Talk to you again in a month's time, and thank you very much for watching.